If you've ever looked into HRT, you've likely been told two completely conflicting things. It will change your life, and it causes cancer. Most women were never told that both of those ideas stem from a single study published over 20 years ago, and that the science has completely evolved. Welcome to the Pause Point. This channel is a space to translate complex medical literature into clear, honest conversations. Today, we are looking strictly at the data behind what HRT actually is, how the safety profile has changed, and what the risks really look like. To understand HRT today, we have to look back at 2002, a major American study called the Women's Health Initiative, or WHI, changed women's medicine overnight. It enrolled over 160,000 women to study the long-term effects of hormone therapy. But one arm of the trial was stopped early when researchers reported increased rates of breast cancer and cardiovascular events in women taking a combination of conjugated equine estrogen and an older synthetic progestin called medroxyprogesterone acetate. The headlines exploded, prescriptions collapsed, millions of women stopped treatment cold turkey. But over the next 2 decades, the global scientific community re-analysed the raw data, and they uncovered massive blind spots. First, the average participant in that study was 63 years old. Well past the age most women actually start perimenopause treatment. Many were more than a decade past menopause. Second, the synthetic hormone formulations used at that time are rarely what doctors prescribe today. When major menopause organizations, including the Australasian Menopause Society, look at the data today, the consensus is entirely different. HRT is recognized as the most effective treatment for moderate to severe menopausal symptoms when started before age 60 or within 10 years of menopause. And that terrifying breast cancer headline? When researchers isolated women in the study who had never used hormones before, the increased breast cancer risk disappeared. Even more striking, for women taking estrogen alone, those who had a hysterectomy and didn't need a progestin, long-term follow-up showed a reduced risk of breast cancer compared to the placebo. Lower, not higher. Furthermore, women who started therapy within 10 years of menopause actually showed a 32% reduction in coronary heart disease. The original fear was real, but the headlines missed the nuance, and the cost of that confusion was decades of women needlessly suffering in silence. So, let's define what is actually happening. During perimenopause and menopause, your ovaries gradually produce less estrogen and progesterone. HRT simply tops up those declining hormone levels to stabilize the system. If you have a uterus, you must take both estrogen and a progesterone component. The progesterone is prescribed because it protects the lining of the uterus from thickening, which helps prevent endometrial cancer. If you've had a hysterectomy, you generally only need estrogen. Occasionally, a third hormone, testosterone, is introduced. While often thought of as a male hormone, women produce it naturally too, and current evidence supports its use specifically for treating low sexual desire after menopause, typically prescribed as a highly targeted gel or cream. When discussing modern HRT, your options generally come down to 2 primary decisions: how your estrogen is delivered and what type of progesterone you use. Let's start with estrogen. You can take it as an oral tablet or absorb it through the skin via a transdermal patch, gel, or spray. This delivery route changes the safety profile entirely. Oral estrogen must pass through your liver first. This triggers an increase in clotting factors, slightly raising the risk of blood clots and stroke. Transdermal estrogen completely bypasses the liver. Robust data, including the landmark ESTHER study, shows that absorbing estrogen through the skin carries virtually no increased risk of blood clots compared to taking nothing at all. For women with risk factors like obesity, migraines with aura, or a family history of clots, transdermal is widely considered the safer, modern pathway. Now, let's look at the progesterone component. The type of progesterone matters immensely, both for side effects and long-term safety. Older synthetic versions are not an exact chemical match to what your body makes. The modern gold standard is micronized progesterone, often called body identical because its molecular structure is identical to your natural hormones. The clinical data here is profoundly favorable. Micronized progesterone shows zero added risk of blood clots, improved sleep because it interacts with your brain's calming GABA pathway, and a significantly safer breast cancer profile. The clinical bottom line? Current international guidelines indicate that the safest, most evidence-based formulation for most women is transdermal estrogen paired with body-identical micronized progesterone. Let's talk about breast cancer, clearly, honestly, and without the panic. The fear surrounding HRT for 20 years is almost entirely linked to this single issue from 2002. So let's look at the absolute numbers in context. If 1,000 women take older combined synthetic HRT for 5 years, the research suggests around 5 of them may develop breast cancer who wouldn't have otherwise. That's half of 1%. While any increase sounds alarming, in absolute terms, that statistical risk is remarkably small. For perspective, you face that exact same statistical risk increase by simply drinking 1 standard alcoholic drink per day, or by being classified as medically overweight. And when we look at modern formulations, the risk profile shifts again. As we noted, estrogen-only therapy actually showed a decrease in breast cancer incidence. And for body-identical, micronized progesterone combined with transdermal estrogen, studies show no statistically significant increase in breast cancer risk for the first 5 years of use. This does not mean there is zero risk. Risk is nuanced, formulation-dependent, and duration-dependent. It demands an individualized evaluation with your doctor. But the blanket narrative that HRT causes cancer, that is simply not what 20 years of refined medical science actually shows. A really important point to make at this point is, HRT is not the right path for every woman. A personal history of breast cancer, blood clots, unexplained vaginal bleeding, liver disease, or a recent stroke all change the conversation significantly. If any of those apply to you, this is not a decision to make without a medical specialist. However, for healthy women under 60 who start within 10 years of menopause, the evidence shows that the benefits routinely outweigh the risks, and those benefits go far beyond symptom relief. First, bone health. Estrogen is vital for bone density. Modern HRT is now recognized by international guidelines as a frontline therapy to prevent bone loss and reduce fracture risks in postmenopausal women. Second, cardiovascular health. This is known as the timing hypothesis. When started early, within that 10-year window of menopause, a comprehensive Cochrane review showed a 48% lower incidence of heart disease. Finally, cognitive health is a compelling area of research today, where emerging data suggests that early estrogen initiation may be associated with a more favorable long-term cognitive profile. Scientists call this the window of opportunity, the crucial years where your body is highly responsive to hormonal support, yielding compounding benefits for your bones, heart, and future health. If you're thinking about having a discussion with your GP, here's how you can approach the conversation. Tell your doctor specifically about your symptoms and how they are affecting your quality of life and daily function. Ask whether your symptom profile and age picture fit a perimenopause or menopause diagnosis. Ask specifically about HRT, including whether transdermal estrogen and body-identical progesterone would be appropriate for you. Ask about your individual risk profile, including personal and family history. An important tip for our Australian audience: when scheduling this appointment, ask your medical clinic if you can book under MBS Item 695. This is a dedicated Medicare item code designed specifically for comprehensive midlife menopause consultations, ensuring you get the dedicated time you actually need. If you've spent years believing HRT was inherently dangerous, and today that narrative finally started to unravel, I'm so glad you found this channel. The science moved on, the medical consensus changed, but the public conversation didn't keep up, and an entire generation of women paid the price in undertreated symptoms. We can change that, but it starts with having the right data in your hands. If this video brought you clarity, please subscribe. The pause point exists to be the exact resource most of us didn't have when we needed it most. I'd love to hear from you in the comments. Had you heard the real story behind that 2002 study before today? Let's keep the conversation going below. Thank you so much for watching to the end, and I'll see you in the next one.